Hi, everyone. Welcome and thank you for attending this month's webinar presented by Suzanne Nelson on simulation for pediatric behavioral health emergencies. My name is Elaine Ng. I'm a co-chair of the Education Committee for IPSS, and I'll be moderating this webinar. For those of you who are not IPSS members, please consider joining society as we offer many benefits to our members, including exclusive access to this recorded webinar and presentation after today's live session. So you can visit our website to see the benefits of membership. So a few quick housekeeping notes before we get to today's presentation. So you can feel free to post questions during the session. In the right side, on the upper right side of the computer screen, you will see a control panel. In the lower portion of that panel, you can type in a question or comment and submit to the webinar organizers. You can do that at any time during the presentation, and we'll clear that up at the end. We'll reserve about 10 minutes at the end for Q&A. All right, let's get to the meat of this. Today, Suzanne Nelson will discuss simulation for pediatric behavioral health emergencies. The session will conclude with an open question and answer period. So Suzanne comes from a pediatric medical, surgical, and emergency nursing background, obtaining her master's degree while working at the bedside. For the past 5 years, Suzanne has worked as a simulation education specialist at Children's Minnesota. Suzanne has a passion for clinical education, patient safety, and systems improvement. Currently, she's completing a pediatric simulation fellowship with IPSS. So Suzanne, over to you.
Okay, thank you very much, Elaine, for the introduction. I'm hoping everyone can hear me okay. I will be discussing my work in simulation, specifically for pediatric behavioral health emergencies that I have been working on at Children's Minnesota. I have nothing to disclose. So our objectives today are to understand the benefits of using simulation-based education for pediatric behavioral health emergencies, and discuss how simulation can be used to develop best practice in the context of managing pediatric behavioral health emergencies. And in the context of maybe using this for a process improvement type or clinical practice change initiative. All right, so I'm going to talk a little bit about Children's Minnesota. We are a 2-campus facility in a large metropolitan setting. We have one campus is a level 1 trauma center, and that's at our Minneapolis campus. St. Paul is a level 3 trauma center. I don't have the exact number of behavioral health related visits here, but you can see here that we have a pretty large stakehold in our community. And plus I have to show off our new 2020 slide deck because it has pretty cute patients on it too. So behavioral health patients are seen primarily in our emergency departments for acute issues, with some subsequently being admitted to a medical surgical unit or an ICU, depending on what the need is, like an intentional overdose or a 72-hour hold, something like that. I want to point out too that behavioral health diagnosis isn't always the reason why our children get admitted for admission. So I use an example like a child that has autism that comes in for surgery, and being out of their element, being out of their routine causes a behavioral emergency with that patient. We also have outpatient psychiatry and psychology services as well for our behavioral health population. And I want to point out too, like many other U.S. communities, there's a severe lack of mental health and behavioral health beds, even more so for our pediatric population. And for Children's Minnesota, that means that we have to sometimes board patients, which means they stay overnight in the emergency department, or if they have to be admitted to a medical surgical unit, and we admit children that may be best suited to a psychiatric facility, but we have to keep them because they have to have somewhere safe to be. All right, so I actually began this work back in 2016 when I was a fairly new simulation education specialist, and at that point I did a brief lit search, and I recently spent a little more time delving into another lit search to find if there was any recent updates or any new things that I should be aware of, partially for this presentation to make sure I was up to date on what was new, and also as I continue the work in other areas, making sure that I'm aware of the current state of affairs. With the assistance of our librarian, I found a few new articles, although from my standpoint and from our librarian standpoint, there's not a whole lot on this subject, specifically as it relates to pediatric patients in an inpatient type setting. MedEd portal showed me a few diagnosis-focused standardized patient type cases. An example would be like a patient with post-traumatic stress disorder. I really didn't see anything that was focused on a behavioral emergency. So specifically something where you would have to de-escalate a patient behavior, the use of restraints, or the use of any medication interventions. It seems that there's not very much data about how to best approach this type of simulation education, especially as it relates to pediatric and focused on inpatient. And when I talk about inpatient, I mean non-psychiatric, non-ED type settings. And then in the same vein, I did some research on workplace violence, as this has become more of a hot button issue in literature and in our healthcare teams. Most articles were focused on perceptions and prevalence of workplace violence rather than simulation-based interventions or education opportunities. And we know that staff are being injured by patients, and this takes a toll on our emotional and physical health of our staff. And this lack of data presented a challenge to me for a couple of reasons, both back in 2016 and in the present. Being a newer simulation education specialist, and when a group reaches out to you and sees you as a simulation expert, while I feel like I have that expertise, how do I use that if I'm not finding the sources when I haven't done this type of simulation education experience before? And I did have some practical experience as a peds emergency department nurse that was helpful in this situation. The facility that I used to work at, not at Children's, had an inpatient psychiatric pediatric facility. And so we did see quite a number of behavioral emergencies in our emergency department. So I had some real world experience. And so for me, it was, how do I pull that together with the research and develop something that was appropriate for staff and that would be helpful for staff? All right, so as I talked a little bit about in the previous slide, we care for behavioral health patients in a variety of areas and for different reasons. And we had, what we had noticed was we had an uptick in patients requiring restraints, requiring medication, and had a small uptick in more behavioral emergencies. And we also noticed that that staff were getting injured in these types of scenarios and in these types of instances. So our stakeholders reached out to the simulation team and said, we want to do some simulation education to provide some education for our staff. So really this began as an education experience for inpatient staff and for ED staff. And once I did some of these simulations, it was clear that there was a lot of things that we could improve on, and there were plenty of opportunities there to work on how we handle these behavioral emergencies. Both during the simulation experience and my debrief, I found out quite a lot of interesting information. And so once these findings were presented, unfortunately, the project sat for a bit. As you can see by this timeline, we had a little, things happen, other things take priority, and it sat for a little bit, and then it gained a little bit more momentum in later 2018, early 2019, when quality and safety had gone to a conference and got really excited about some of the work that was happening and knew that we were doing some work in simulation and wanted to take some of that knowledge that they had learned and really push some of this education further. And what we wanted to do was develop clear practice in regards specifically to roles in a behavioral emergency. In a behavioral emergency, there's a lot of emotionally charged. People are yelling at you, families are upset, the child is upset. They may be saying things to you that are really hard to take in, and knowing that they're maybe not doing things to you, but it's really challenging to try to rise to the occasion in those types of emergencies. And so how do we develop good roles so people know what to do in these types of emergencies? And looking back on this first experience, really that first round of simulations that I did before quality and safety came in, it served as a kind of almost a needs assessment and a baseline in which we could develop our education and further some process improvement around behavioral emergencies. So really the first ask was, hey, we need this simulation education, which simulation is happy to do. And then it turned out that the issue is a lot more layered than we initially had thought, that, oh, I'll just do these simulations, we'll find some stuff out, we'll do some more education, staff will be great. What we found out was that we needed to do that, where there were a lot more opportunities to help our clinical practice get more refined and really take our behavioral emergencies to another level and ensure that people are being safe. So once we regrouped, we decided to develop a goal to align the way that we handle behavioral health codes similar to how we handle like a code blue or a medical resuscitation. We do a lot of practice in mock codes and doing those things, and we wanted to align the roles and the teamwork behavior that we worked really hard on and transfer those skills to how we handle behavioral health emergencies. So I'm going to spend a little bit of time now talking about how we implemented this part of the plan and this part of the project here, from the point of where we decided to do more of a quality improvement spin on the simulation, and then how we implemented some of the simulation education for this. All right, so a little bit about the stakeholders in this work. As I mentioned on the timeline side, we have this group. It's called the PABC, and it's the Committee on Patients in Acute Behavioral Crisis. And that is a large committee, and it's made up of psychiatry, quality and safety. We have representatives from our emergency department, our medical surgical units, social work, security. So it's a pretty large committee that oversees how we handle patients in acute behavioral crises. They track data, they see how our documentation looks. They really have a high stake in how these emergencies are treated. Additionally, I worked with some representatives from all of these groups. Initially, that first simulation that I conducted in 2016 was just with the PABC, but in subsequent findings, we realized we needed to include more representatives from these groups in order to move forward this process improvement. So we had our hospitalist group involved, our quality and safety. We have some coaches that work at different areas of the bedside that were really helpful. Nursing staff, specifically from units that took care of the most number of patients experiencing behavioral health emergencies, and then security. All right, so we use the PDSA method for the second part of this project, which is the Plan, Do, Study, Act. And we did some simulations within this process improvement lens, and then we wanted to take the findings and work through some of this role definition and conduct subsequent simulations with changes in place, focusing on the context of how can we refine our roles in a behavioral emergency and demonstrate those teamwork behaviors. Again, this requires a lot of collaboration and identifying the key stakeholders when we join together. And any of these types of policy changes, we want to make sure we have all the right people at the table. And so attempting to improve the process of a behavioral emergency requires the input of several key collaborators in this. It's important to consider this whenever you're attempting any sort of change implement, and especially with behavioral health, because there are so many groups responding to this type of emergency, we want to make sure we're including all those that are key stakeholders in this work. And this also ensures we aren't missing any details, that we're seeing all the proper lenses in which we could create good process change, and making sure that our changes make sense for the work that people are doing. So these are the roles we have identified for our behavioral emergencies. These are all identified from the initial simulations and as well as our current hospital policies. In this case, the code leader is the hospitalist for the patient. So this could be, it could be a physician, or it could be a physician assistant, it could be an NP. The bedside nurse in this case. CSA for us, the CSA is a nursing assistant. We call them clinical support associates at our facility. Social work, security, emergency department staff, pharmacy, and then any additional floor staff, and that would include any other nurses or CSAs on the floor. So this is the initial roles that we, between the policy and our brainstorming, is who do we absolutely need to have there? Who are the most important people to have in a behavioral emergency? All right, from there, we joined together to develop a simulation to practice the roles we had defined using our stakeholders and collaborators. For the subsequent process improvement simulations, we used a scenario. It was similar to the one that I had used to develop this work earlier. It was we chose to have a 17-year-old with a known behavioral diagnoses of depression, anxiety, had some issues with aggressive behavior in the past, that was being admitted for a 72-hour hold for suicidal ideation, and who subsequently escalates their behavior that requires meds and full restraints. In addition, we overhead paged the simulation behavioral code like we normally do in our facility. In this case, we used a standardized patient actor, and using an SP for this type of simulation makes the most sense. The literature used that I reviewed, most of them used a standardized patient, if not all of them used a standardized patient for this type of simulation. It makes the most sense in this type of situation because we wanted that real-time emotion, we wanted that real-time feedback of how am I going to respond to this person? What do I need to do for this person to help de-escalate their behavior? We at Children's don't have a standardized patient pool of people to use, so I had to get a little creative. In both simulations, we did use an adult that played a teenager. In this case, we actually asked our Child Family Life group if they would help us do this, and so we had a representative, one of our Child Family Life staff members helped play the patient in this situation. And this is actually super helpful because they have a really good understanding of the appropriate developmental levels of children. They have a really good understanding of what it means to have a child with autism, and they understand how a 10-year-old is different from a 17-year-old, and so they could really get into that understanding of the mindset of this person. So I spent some time training this SP, and part of the training included, explaining the objectives of the scenario, what we were trying to get at, and how she should act when somebody says this to you. I want you to respond with this. If they do this, then I want you to do this. And making sure that she understood how she should respond to various things that people could say to her, and then how she should act too. So being like pacing the room, maybe not being very nice, using nice language to the participants. So one of the actors I used, it was hard for her to use curse words and stuff, but part of that is important because that is the kind of thing that people see, and they see children getting really upset and using language that they wouldn't normally use at adults, but they're just in a tough place and having a hard time and don't really know how else to express themselves. An important part of training a standardized patient actor too is thinking about all the safety considerations that you need to have, especially with this type of simulation, because we're working in an emotionally challenging situation. We're using restraints. We are talking to a patient who's really agitated, upset, that we need to make sure that the patient actor is safe and feels safe in the situation and has an out if they need that as well. So what we did as part of the training was we decided on a safe word, and if she had said that safe word at any point, during the simulation, that would be, okay, we're going to stop the simulation. Just to make sure that she knew that even if, because it's a simulation, yes, it's not real, but when you're performing in a simulation that has this emotionally challenging component, emotionally charged situation, it's easy to get swept up in it. And I wanted to make sure that she understood that if it got too much, that we could stop at any point. And I also made this clear to our staff. So once they responded to the event, I said, okay, you're going to go in and you're going to care for this person in there that's having a behavioral health emergency, but if at any point this isn't safe for her, that we're going to stop the simulation, and that we're going to stop what we're doing and we're going to just debrief from wherever we're at. I also stayed in the room with the patient and just kind of checked in with her and just kind of made eye contact, like, yep, you're okay, we're okay. And where we were able to conduct both the first round of simulation and the second subsequent round, which I'll talk about in a little bit, all the way to restraint application. So it was really, really helpful to have a patient actor that felt comfortable and was able to do that effectively. All right, so some of the findings after our initial simulation, and I'm talking about the one where we're focusing on roles now. We discovered a few important things. One was about roles, and there was some confusion as to what staff should be doing in the room, and some of the bedside staff were like, I want to help, but I'm not sure what I should do. I want to help the bedside nurse, but I'm not sure if I should come in the room. If that person's really upset, I want to help, but I'm not sure what to do. It was a common theme. In one simulation, the pharmacy was not really available to retrieve meds, and so there was a little bit of confusion about, well, I didn't know I was supposed to come, and so we're trying to work through some of that. Another thing we found was some of the language that we were using during these behavioral emergency simulations was kind of challenging and maybe not completely ideal in the way that we speak to patients. And again, we're in this very emotionally challenging environment. You might have, I know for myself in real life, you have a patient throw a chair at you and it's really hard not to get upset by that. Or if somebody calls you stupid or whatever that is, it's really hard not to fire back at that person. You have to try to maintain that neutral tone and trying to maintain that calmness. And one thing that struck me at one point, and that they said, oh, we're just going to tie you down for a moment. And so really thinking about in how we're speaking to our patients that are having behavioral emergencies is really important, considering their developmental level. And in other types of situations, saying that you're just going to tie somebody down without really explaining anything could be very confusing and could be detrimental and even escalate the patient further. So we really wanted to, when we talked in our debriefing, we talked about language and what kinds of wording would you use differently? How might you say something differently to this patient to help them? And then, of course, there's always the teamwork behavior opportunities. So lack of call out. So people all kind of grabbing the patient at once without saying, oh, hey, I got the left leg and you could get the right leg and I've got the restraint box and that type of thing. So working through some of those teamwork behaviors and how can we develop better strategies to make sure that everybody is on the same page when we're dealing with this type of emergency. Okay, so based on the findings from that first simulation, our work group met again, and we worked on refining the roles based on the findings of that first simulation and feedback from the group debriefing, as well as the standardized patient input. And a couple of changes that we made based on the findings between all of the debriefing and some of the things that I observed. We talked a lot about the role for the ED. Our emergency departments, like many, don't have a ton of people to just send people to respond to other units. And so it's really challenging for the ED to send multiple staff to help with these emergencies. While they do want to help, what do we actually need from the emergency department? How can we best utilize their expertise, but yet maybe not embroil them so much in the emergency so they can have an out to leave when they need to, if they have to respond to their own traumas and their own behavioral health codes. One thing that we decided to do is eliminate one of the staff members from the ED, as we felt like we didn't really need that person since we had enough people responding between the units responding, from the hospitalists responding, from security responding. We felt like we had enough players that we just needed that ED charge nurse to help kind of direct things and maybe help with some medication administration duties. And that way she could just hand off and head up, or he or she could hand off and head back to the ED when needed. We also refined a little more of what pharmacy's role is and how that looks. And then talking about how does that medication administration process look for between pharmacy getting an order, how does that whole process look for the patient. We also talked about what the hospitalist has to do as far as documentation and making sure those things are clear in the policy, as well as when we're responding to these types of events. A couple other things we asked ourselves too is how many people, what's our ideal team look like? So is our ideal team 12 people or is it 6 people, and how does that look? Because during the day, we're going to have a much different response and number of people that are able to respond versus a night shift when we have less people working. We have one pharmacist or 2 pharmacists working, and they might not be able to respond. So based on some of the changes, or excuse me, not some of the changes, but between the talking about debriefing and talking to staff and working with stakeholders, we worked through updating and refining some of those roles. All right, just a behavioral health emergency is a pretty emotionally challenging and charged situation, and I think it's emotionally different than medical resuscitation. You're dealing with people, and yes, you're dealing with people when you're dealing with a medical code, but in my experience, it just feels very different. It feels very different for me to work with somebody who's experiencing a behavioral emergency versus working with a trauma, for example, a trauma emergency. It feels very different. And so there were some challenges related to this work, and I'm going to talk a little bit about some of the challenges in implementing this type of simulation. With any simulation that involves multiple units, multiple departments, it can be really challenging to try to coordinate schedules to ensure that all proper personnel are available to participate. And secondly, you want to make sure you're asking the right people through the right channels. So if I'm trying to get a hold of somebody in the hospitalist group, who do I need to talk to, and knowing which admins work better, knowing how everybody's schedules are different, And so just having a better handle on understanding how all of those different departments have different priorities, and so how do I navigate that, was a little bit of a challenge in making sure I didn't forget people too. And part of understanding and improving a process includes replicating the entire process. And part of replicating that entire process for us was doing the overhead page. And the way we overhead paged it was, we said, what we call a behavioral health emergency at Children's, we call it code green. So it would, the simulation, code green, drill, please respond as you're able, and we just said what the unit was. So making sure that we announced it appropriate so people knew that, yes, it was a simulation and we wanted them to respond, but we still wanted to see how long does it take people to get there, and how do people filter in, and then where can we fix some of the process and roles as people start to show up for this. One of the challenges we ran into is I thought that we had everybody notified, but it turns out I had missed somebody, and so working through, like, how do I work through making sure, okay, I got to make sure that if we do this again that we include this group on there, because I thought that we had everybody, but it turns out we didn't. And in many simulation experiences, we hope and that people will let go of the disbelief that this is a fake, this is fake, and embrace the education opportunity. And I would say having a standardized actor and doing the overhead page and having as much realism injected as possible, I think that we did a pretty good job. And having an SP that was comfortable and well-versed in the needs of this training was really important for success. And there's always going to be those that can't really suspend their disbelief, but I think the more that you can overcome this, the better your outcomes will be, if that's what you want out of your simulation. Finally, I had mentioned before, we're a 2-campus institution, and while we try to be as one, they're 2 very different campuses. They have different cultures. They have slightly different needs. We have 2 different levels of trauma. We have there's just different nuances that we have to account for when we're developing processes and when we're developing clinical policies. And we had, at that point, when we were doing some of these simulations, we have 2 different security teams, meaning they were overseen by different people. And so they had a little different philosophy and different kind of nuances on how they handled behavioral health emergencies, and needed to understand the differences between that this is a pediatric patient, that we are not going to treat them like we treat other adults, and that there are certain nuances that are important for them. Okay, so now I'm going to talk a little bit about some of the lessons that I've learned from all this work, and then briefly talk about the next steps and where this work is at our current state, and then talk a little bit about what I'm hoping for the future and some of the future work that is occurring. So I briefly discussed, having these stakeholders and understanding collaboration and understanding all those pieces when you're developing a multidisciplinary, multi-department simulation. And in retrospect, and one of the biggest lessons that I learned from this work is that while it's important to have all the important stakeholders there, is how do you develop a champion or have your go-to person from each discipline and stakeholder. And that's that person that you can rely on to help you develop policies. They serve as a content expert reviewer for any changes that you're doing. And it helps you get the buy-in that you need to do some of this work. And while I did have a lot of stakeholders, I don't know if I fully had champions from the disciplines that I really needed them from. And so as this work is continuing, I'm starting to develop better relationships with some of these champions from each discipline so we can start to propel this work forward and continue this work and refine this work and get it to where it needs to be so we are keeping staff safe and we're keeping patients safe. In addition, when I initially shared findings from the first round, so this is not the first round with our quality improvement project, but back when I first started this work, not all the important stakeholders were present, and that led to some confusion about, well, what does this mean? What do we do with this stuff? I didn't know you guys were doing a simulation. I never heard about this, that type of discussion. So there was some confusion about what we should do next. And I made the assumption that certain people were at the table when I was sharing these things, and it turns out that that wasn't the case. So now, in subsequent sharings, I've really tried to make sure, okay, who needs to be there? Who do I need to share this with? How does that look to those as we're moving forward, as we're making changes? Who needs to be involved in changes? Where are we at with developing more simulations? And then making sure that we're having everybody understand the findings and what we're recommending as a group. And this would include executive leadership if that's what's needed. And I want to ensure that everybody that would be affected by any policy updates or any process changes are well aware and that they've been able to provide appropriate input and really contribute to the work of this. Because it is really important work and it's so multifaceted and it's multi-department and it's multidisciplinary that we have to make sure that we have everybody there and everybody understanding what the needs are. All right, so it's actually more current and future state. So we've conducted conducted 2 rounds. We did the 1 round with the role changes, and then we did a 2nd round with after the role changes, and now we're working on let's do some more simulations with changes in place and doing them on units that maybe don't have as many behavioral health emergencies, but still want that training and want that experience, and also doing future sims in other places or even places that we've already done them to make sure that our changes are working. Where else do we need to be with this work? Where are we at with the teamwork behavior too? So eventually, we would like to work on other areas of this process. So maybe focusing on some of the team steps behaviors and teamwork behaviors, and how can we infuse some of that piece into our language, and how we could do this both in our education pieces and in our policy development. And targeting other areas, we have since started and some other things are happening in our ambulatory areas as well. These areas see quite a number of behavioral health patients, maybe not in an acute situation, but they do see patients and they do experience some behavioral health emergencies too. And their training is currently fairly limited. So we're in the process of developing some education that provides both some education and how to de-escalate, how to doing some role play, doing some work and training that suits this group and is appropriate, helps them identify resources. It's not just the clinics. There are clinics that are on the outskirts and are not in the Twin Cities area where they would have to utilize other resources if they're truly having an emergency where they would have to call the police and that type of thing. So we want to make sure people understand resources in the ambulatory areas as well, but then also give them some training so they feel comfortable and they're maintaining that same level of safety that we strive for in the inpatient setting. Okay, so in summary, behavioral emergencies challenge staff in ways that a resuscitation does not. Therefore, it's important to consider the role that simulation-based education could play in providing opportunities for staff, both in staff training and process improvement. All right, that is all I have. So I'm happy to take questions.
Great. Thank you, Suzanne, for a very informative presentation. There's certainly a lot of challenges that we may not have considered. So it sounds great, but I'm sure it's a lot of blood and sweat that went into it. So we have a bit of time for questions. As a reminder, participants can submit written questions by typing them in the webinar's control panel, and I'll read them. I see there are 2 there, but I'll start with my question.
Okay.
This big deal. This is a big production. So can you enlighten us? How long are these simulations, and then your debrief? Do you have observers, and then because so many people have
sure.
a piece in this you want to watch.
Yeah, absolutely.
So when I do some of these big,
absolutely.
then it's chaotic. Then you have there's already a lot of people participating. Then there's more people observing and facilitating. So it's difficult. Just tell us like the logistics of this.
Sure. So the simulation itself lasted about, I would say, half an hour, and then we spent about a half an hour to 45 minutes, an hour, depending on people's availability to debrief. The first ones that we did, we videotaped. I didn't videotape the ones that we were doing the role process improvement stuff. So we did have some members, some of the key stakeholders served as observers. And so they were kind of in the periphery of like the patient room to observe. And I didn't mention this, and I'm realizing I had some observation sheets that I used so people could see different questions to write down, like, what types of de-escalation behavior did you see? What type, how long did it take from time that code was called to how long it took to get restraints on, and just looking at some of those things. So looking at who was in what role, what person was doing what role, and that type of thing. So we could structure our debrief a little bit, because there are so many people, like you mentioned, Elaine, involved in these types of simulations and these types of emergencies. And we want to make sure we're hearing from everyone. And so it was helpful to have those observation sheets to kind of structure our debrief somewhat, so we could get good feedback from people.
Right. So there's a question from the audience. Did you find a specific time of day that you found to be the best, since so many team members are involved, and I'm sure there are still patients being treated in the area? So how do you handle that?
You typically did the afternoon. Like the ones that I did were typically like after lunch, but before like evening shift started. So like that 1 to 3 time period. And yeah, that worked pretty well. And then as far as like we overhead paged it, we with the caveat that please respond as you are able. And then we had some signage up on the inpatient units that we were working on that said, we're doing a simulation. And then we purposely tried to find areas where there were less patients. We're lucky enough, our facility has we have like an overflow unit. So the first one we conducted, the unit was empty. So the person could yell and swear and do whatever, and we could have 40 people on the unit, and it wouldn't be disruptive to any workflow of that particular unit. That's not something that very many institutions have that luxury. And I mean, our overflow unit is currently full because it's flu season. So, that type of thing, we can conduct that. If we had to, we could have conducted it in our simulation suite area too. But really, it's just communicating well with the units and making sure they know that just like, okay, there's gonna be a lot of people here, making sure families know we're doing some training. So if you hear this and this and this is what's happening, and making sure they're all aware of what's going on.
Right. So you mentioned yours was a 17-year-old child life specialist pretending to be a patient. So what about younger children? How can you create a scenario with a younger, like a 10-year-old? There's a limit how much you can pretend to be a child or 8-year-old.
Yeah, and we talked a lot about that because we were like, okay, how do we, it's really, how do you make, an adult look like they're 10? That's not really very possible. And so we chose to do the teenager route. And I think now that we've done this a few times, we would like to explore, like, how do we do this, making the patient look younger, or is there somebody that's shorter that looks a little bit younger? Can we make do with using an adult person acting as a child? And that's where, we'd like to explore that more now that we've done kind of the teenager thing, because a lot of our behavioral emergencies are kids under 12, and how do we handle those too?
Right. Other questions from the audience. There's a high presentation, she said. Do you use a room in ED? Maybe she hasn't quite finished reading the question. Maybe you can answer that bit first. Do you use a CAD for these type of patients?
Okay, Elaine, I kind of broke up. I'm wondering if you could just repeat the question.
Yeah, so the question is, do you use a safe room in your emergency department?
I'm sorry, I still didn't hear.
Do you use a safe room? Like, I guess it would be
a safe
somewhat.
Room. Yeah.
We had it minimal furniture.
Yeah,
I would think that's how.
Oh, okay, gotcha. We do not have safe rooms in either of our EDs, but the ED that I worked in previously had a safe room.
Okay. So other questions. Does your pharmacist bring the for them, or are these type of meds kept on all units for easy access?
So it can go they can do it one of two ways. So one, they can get the meds from IPSS if they need to, but there's typically that's not able to get override quick enough. So what we do have is an emergency medication box that the ED brings, and that has some emergency medications like Ativan, Valium, Haldol, Benadryl, and a couple other medications. So the ED actually brings that box, and then pharmacy helps do the administration piece of it, or drawing up of the medication, and then the ED nurse either administers it, helping or having, and along with like the bedside nurse.
And are these real meds they're using?
We just use a simulated med box that we have. I have a mock-up of a simulated med box that we just replicated, but that's what they would really bring. And so what I did was when they arrived with the real box, we just like gave them the fake one.
Okay. More questions. Aside from safety measures for your SP, how did you get the buy-in from hospital administration to restrain the SP? It was a huge hurdle for this person when they tried to implement a simulation.
That's so based on some of the reports that this PABC that I spoke about previously, they had some issues around when restraints were done, and so part of why they wanted to do the simulation is they actually wanted to see that restraint process. So part of what they wanted was they wanted us to restrain this person, and so that was challenging for me because like I have to ask somebody like, are you okay being restrained with the being part of the simulation? And but yeah, leadership was actually the one that made the ask, so that kind of eliminated that for me.
Okay, so moving on. Did you use for the debrief? Did you use any specific framework? Do you have multiple debriefers or just one person?
I was the main debriefer, and then we use Pearl's So I use Pearl's debriefing for how I briefed it. And the last one that we did, I think there were 30 people. And so it was really challenging to kind of keep that many people focused because there was a lot of side conversations. So I think if you're going to have a larger group, having a co-debriefer would have been a little more helpful for me to just kind of keep people on task, because people are having side conversations and I'm like, okay, I want to hear what you have to say, because I'm sure what you're saying is going to be super valuable to this work. And so I want people to be able to speak, but it's intimidating to try to speak up in a group of 30 people too.
Right. Have you run any scenarios in the pre-op or PACU area? And if so, was there any discussion about who prescribes if meds are needed?
I have not been in the PACU area yet, and this is something that we've talked a little bit about this, and we have another day surgery site at another area. So technically, I guess we have 3 campuses, and so we've talked about how do we do that. And typically, what they decided is they would have the anesthesia order medications for them, because they have had a couple of incidences where they had to order medications for a patient that was having a behavioral crisis.
Right. So in an ideal world, how frequently would you want to have this simulation?
That's a good question. I would like to do these. It's really challenging to ask an SP to do this multiple times, because I think it's a kind of a challenging thing to have people to perform. Ideally, I'd like to do this more than once a year. I mean, right now we're only done them like once or twice a year. I'd like to figure out a way we could do it where maybe it wasn't so intense, or if there's a different way that we could still get people in the moment, but maybe not have like all the resources, all the stuff, but still be able to provide a rich experience. And that's where I'm at with is how do I maybe do this on a smaller level, but still have the same impact.
Right, because I guess you've kind of now refined your policy and the process. Mm-hmm. So now it's about making sure it works in different settings. Is that fair to say?
Yeah, I would say so. That's fair to say. And then are the roles really where we want them to? Because we've only done one other one after we refine roles. Is this really where we want it to be at? And I'm not sure if we're quite there yet. And then, every time we want to have a simulation, we have so many people that we want to get involved. Like, can we get away with just doing something without an SP and just talking through it? Is that going to have the same impact? I'm not sure.
Right. Another question. Are you planning to present this at IPSSW?
I'm presenting something different, but I don't know. I could.
All right. We'll have a chat about that. I only have a question left of my own, but we have time. Mm-hmm. So if anybody else wants to submit questions, do so. So my question is, like, how many times you have a safe word built in? How many times has it been used?
I never had so I've done a total of 4, and all 4 times none of them used the safe word.
Have you, in your whole life, in your simulation experience, have you ever had to use a safe word?
We did when we were doing a math test.
In for a standard resus type simulation, do you?
What was that?
Do you build it in your usual standard resus simulation to have a?
I haven't. That's a really interesting question. I have stopped simulations because of a safety issue, because we were defibrillating and things. I was like, nope, we got to regroup here. And we did we were doing a mass casualty event, and we did use children as SPs, and we did have to stop a couple because they weren't saying the safe word, but the look on their face was, we have to stop what we're doing because it's getting a little too intense. So I have had it happen, just not in this context.
Great. There's one more question. It says, I think it is saying that there is not much literature about these types of emergencies. Would you like to gather research in the future related to impact of simulation of care of patients with behavioral concerns?
I think the lack of research means that I obviously need to get on that. One of the things that I would like to do is write this specific up for a MedEd portal submission, but I'm not quite there yet.
Great. So more work to do. Isn't that awesome?
Yep.
More.
Yeah.
All right. So we're almost at 5:30, but seriously, if you have a question, like a short one, we can entertain that. If not, I'm just going to say my closing things. I'll keep an eye on the question box anyways. But thank you all for participating in this webinar, and thank you so much to Suzanne for sharing your work with us. So the participants will get an email from IPSS that includes the link to an evaluation. So take a few minutes to access it and provide your feedback on today's session. The recording of today's webinar, along with the handouts, will be posted on the members-only IPSS website in the near future. So a reminder, registration for IPSSW 2020 is currently open. So early bird pricing is available until March 20th. If you submit an abstract, you'll be notified by February 3rd. And the conference, as you may know, is in St. Petersburg and Tampa from April 26th to 29th. We hope to see you there. We have a next webinar, which we'll be advertising soon. Actually, the next one may not be the next one, but anyways, because I was just kind of maybe slotting one in. But one of the next ones is about poster presentation. So we have someone to talk, not me, someone else to talk about how to create a poster. And then we have invited other award winners, IPSS fellows from the past year to present. So stay tuned and we'll have more. So I'm going to take a quick look, make sure I've covered all the questions being submitted. It seems like I have. So I think we should stop there now. It's 17:28, which is pretty close to 5:30. So thank you all. Have a good day, evening, night, wherever you are. And we'll see you again soon.
Thank you.